Good morning. My name is Quinn Peck. I am the Medical Director of Cardiac Rehabilitation at Baystate Medical Center. I am active in the AACVPR and am the Vice Chair of the Quality Care Committee. That gave me this role in helping develop the performance measures. I was lucky to be able to choose my two greatest passions, which are both tobacco and cardiac rehabilitation, and put them together in a nice package, which I hope you enjoy together today. The title of my talk is Tobacco Use Intervention Performance Measure for Cardiac Rehabilitation, and this will last about 20 minutes. First of all, I have no disclosures and no conflicts of interest or no personal financial ties to this work. As we all know, smoking is the #1 cause of preventable death in the United States, and it leads to 400,000 deaths per year. And we know that smoking is a major risk factor for all kinds of diseases, but particularly heart diseases. And interestingly, about half of patients with ST segment elevation myocardial infarction are smokers. So this is something we see every day. The only problem, and then smoking and heart disease, we know that the vast majority of people who are just hospitalized with a fresh heart attack really want to quit. But yet, only about 35% of them succeed in staying quit 1 year later. And the thing that I have thought about again and again is this median time to relapse. It's just 19 days. So most of us enroll patients into cardiac rehabilitation somewhere between 2 and 4 weeks. But by 2 weeks, half of the people who have relapsed will have already relapsed. So this is an intervention that we need to be aggressive. We need to help them quickly. We need to work with the hospital providers to give them an ideal chance at quitting smoking. And cardiac rehabilitation is part of that solution. And so here's a few things about smoking cessation in cardiac rehabilitation. First, as a group, smokers unfortunately are half as likely to attend cardiac rehabilitation. We don't know the reason for this, but smoking does seem to be a factor that causes people to not come or is associated with their not attending cardiac rehabilitation. However, the smokers who attend cardiac rehabilitation seem to be twice as likely to stay quit in the long run. So we're providing a benefit and a support there for these people. And it has been clearly shown that nursing interventions in cardiac rehabilitation have helped smokers quit and stay quit permanently. So there's really a good evidence base for having a good smoking program, a smoking cessation program in cardiac rehabilitation. We also know that effective over-the-counter medications are available. So these are tools that you don't even have to ask a physician for, that you can incorporate into your cardiac rehabilitation treatment planning. So as we worked to develop this performance measure, there was some concern that was raised about the ability of cardiac rehabilitation programs to truly influence smoking cessation outcomes. And while I do think we can make a difference, program managers all felt like to be judged just based on whether or not somebody quit smoking was concerning. So as a result of that, and to be flexible, we changed the current measure into a process measure rather than an outcome measure. In other words, we're going to measure whether you are actually doing something to help your smokers rather than if they quit or not. And as all performance measures, there may be some modifications and updates in the future or slight tweaks to these measures, although what I think we've got here today is a very solid performance measure. But you may see this be modified, or you may see it become an outcome measure in the future, meaning in the next 3 to 5 years. So right now, our measure objective is to have 100% of smokers receive an effective intervention that will help them quit smoking or will help them to stay quit forever. That's really what we're after here. And here is the measure. So the measure description is the percent of patients participating in the cardiac rehabilitation program who receive a tobacco cessation intervention if identified as a tobacco user, or who received a relapse prevention intervention if identified as a recent tobacco user. Now, tobacco use is defined as any kind of tobacco product in 30 days prior to enrolling in cardiac rehabilitation, and this includes cigarettes, cigars, cigarillos, chew tobacco, and e-cigarettes. Recent tobacco use is the same forms of tobacco, only it required use in the prior 6 months. And the 6-month window will require many of our programs to change their approach to identifying smokers. We know from the data I just showed you that 6 months seems to be the magic time where if they're going to relapse, they will have done so. And so we want to make sure we support all smokers who are in that first 6 months of a smoking cessation attempt, because we know that relapse is so common. So that brings us to the actual numerator, or the people who qualify for this performance measure. The numerator is defined as a patient who received a tobacco cessation intervention, if they're identified as a tobacco user, or a patient who received a relapse prevention intervention, if they're identified as a recent tobacco user. So these are the interventions. We've already talked about who qualifies as a tobacco user, but these are interventions that would count for the numerator. So tobacco cessation counseling. And if the patient's not willing to make a quit attempt, we should really focus our counseling to help them improve their readiness. And there are multiple techniques that have been described, including the 5 R's, but we won't go over those today. Another option is to provide a tobacco cessation pharmacotherapy. And there's a nice literature suggesting we can provide medications for patients who aren't really quite ready to quit, but maybe they're willing to reduce the amount that they smoke through the use of a nicotine patch or a gum. And then thirdly, you could refer a patient to the tobacco treatment program or specialist. Now, we also have another category very similar. It's called relapse prevention intervention. And I think these are probably underutilized in cardiac rehabilitation. But here they are. Again, it's a tobacco relapse prevention counseling at program entry, tobacco cessation pharmacotherapy, and referral to the tobacco treatment program or specialist. So it's not enough to see a fresh non-smoker who is 15 days from their MI and hasn't had a cigarette. They are still really at high relapse risk. So we really need to coach them about ways to avoid relapse, triggers for relapse, how to avoid or how to deal with the stress that comes from drug withdrawal, how to teach them to use these medications so that when they're in their high-risk circumstances, they can really avoid a relapse. Again, we already talked about that relapse is incredibly common. So just because somebody walks into your program at 30 days and hasn't had a cigarette doesn't mean that they are done, and we need to help support them. And that's the purpose of this relapse prevention intervention. All right, so the numerator, in order to qualify for this numerator, though, this cessation prevention intervention must be documented in the patient's outpatient cardiac rehabilitation record. So it's not enough for the primary care provider or the cardiologist to prescribe the medication. And so we specifically say if it was done by somebody else, then you need to document it in your cardiac rehabilitation record in order to qualify for this measure. So we must assure that something is happening to help these people quit smoking or to stay quit. All right, now the denominator. Who qualifies for this measure? The denominator is the number of participants in the cardiac rehabilitation program during the measurement period who were identified as either a current or a recent tobacco user at program entry. And that includes all participants regardless of the length. So if they came in and did only 1 session with you, you need to document a tobacco use intervention. It's that important. The exclusions are documentation of a medical reason for not doing a tobacco cessation intervention, such as limited life expectancy. We expect this to be pretty uncommon. All right, now here's the flow chart. You can see that D1, D2, and N are highlighted and larger. We're going to use those in a little math equation in the next slide. So here's the flow chart. Has the patient used any tobacco products in the past 6 months, including e-cigarettes? And if the answer to that question is no, they don't qualify for the measure. Now that splits us into two groups. There is the current user and the recent user. The current user is anyone who's used tobacco in the last 30 days, and they are included in the denominator. Or recent users, anyone who used tobacco in the last 6 months, because they're still at high risk for relapse. Then there's a question, did you document it in the outpatient cardiac rehabilitation record in both cases? And if it's documented that we performed an intervention, they received the intervention, and they're included in the performance measure, we hope this will be 100%. But if there's not documentation or they did not get an intervention, do not include them in the numerator, whether they're in the current or the recent user group. Here is the simple math. You take the numerator and you divide it by the two denominators, and then you multiply by 100 to give you a percent. And again, the performance measure is the percent of patients participating in cardiac rehabilitation who received tobacco cessation intervention and received a relapse prevention intervention if identified as a tobacco user. All right, so to put some very specific examples on this, we'll run through two examples. Here's example one. So let's take a 70-year-old woman. She enrolls into cardiac rehabilitation 6 weeks after her bypass surgery. She smoked her last cigarette on the day prior to her hospitalization. So as she's currently using a nicotine patch, and the staff member provides brief tobacco relapse prevention counseling. Although she did drop out of cardiac rehabilitation after only 2 weeks in the program. So does this patient meet the denominator? Well, yes. She is a recent tobacco user who needs a relapse prevention intervention because her last cigarette was within 6 months. Does she meet the numerator? Yes, she meets the numerator because she was using a nicotine patch and she received a brief tobacco cessation advice from the staff member. It could be either, but having both is both the right thing to do and a good thing to do. Here's example two. So there's a 55-year-old man who enrolls 3 weeks after a STEMI, and he was treated immediately with PCI. And he was prescribed by varenicline at discharge by his hospitalist. Since his hospitalization, he has stopped smoking cigarettes, but he just started using an e-cigarette in the past 4 days. So the staff member does provide some counseling, but doesn't document this counseling and doesn't document the varenicline medication in the outpatient cardiac rehabilitation record. So does this patient meet the denominator? Yes, he meets the definition of an active tobacco user because his last cigarette was within 30 days. In addition, he's also using an e-cigarette, which makes him an active user even if he had been more than 30 days. Does he meet the numerator? No, he doesn't meet the numerator because the staff member did not document the tobacco counseling or document the use of varenicline. It's not enough to just talk to the person. You need to write it down and prove that you did it. They wouldn't, in this case, the staff member wouldn't have even had to do counseling because the patient was prescribed by varenicline by their cardiologist. But in this case, I think the right thing to do is to talk with the patient, coach them, help them understand their triggers, work with them to identify high-risk situations and to help prevent relapse. So in summary, we know that tobacco use is a major problem. We know that cardiac rehabilitation is definitely part of the solution, and it is now becoming a marker of program quality. We really need to do the right thing for our patients. We really need to counsel them, coordinate with their primary carers, get them the medicines that they need. Ideally, we'd be doing all of those things but this performance measure requires that you only do one. And we really hope that this performance measure will help you improve the care that you deliver to smokers, to make sure that they're getting counseling, to make sure that they're getting medications, to make sure that they're getting the support that they need, in addition to the exercise and other good quality care we're providing them in our programs. And with that, I'll leave you with a quote that I really like. Quality is never an accident. It is always the result of intelligent effort. A lot of effort has gone into making and creating these performance measures. It's been a 2-year process. And similarly, in your programs, you're not going to have good performance measures unless you are really making an intelligent effort to systematically assure that every patient is getting a quality experience in your rehab program, and that it's not helter-skelter here or there. Instead, it's 100% of patients, and that's really our goal. I know many of us do really well with this. We want to make everyone perfect. That's the goal. We'll get there step by step. Thank you for your time. Thank you for listening, and please email me with any questions or AACVPR leadership with questions. We'd be happy to answer any issues that arise. Have a great day. Bye-bye.